Justin is a consultant gynaecologist at the Birmingham Women's Hospital and an honorary professor at the University of Birmingham. His clinical experience in the management of general gynecological conditions, especially the treatment of menstrual disorders, fibroids, ovarian cysts, pelvic pain, and endometriosis. Justin's research evaluates health technologies, care pathways, novel medical therapies, and minimally invasive surgery to manage abnormal uterine bleeding, pelvic pain, endometriosis, and early pregnancy loss. Over to you, Justin.
Thank you very much. Thank you for inviting me and giving the opportunity to present our work, which has been published in the British Medical Journal. So I'm going to speak to you about endometriosis and the trial we did to look at preventing recurrence over the medium and long term using commonly used hormonal contraceptives. Next slide, please. So endometriosis is a common condition. 1 in 10 women, we estimate, have it. It's a condition of women of reproductive age, so women before the menopause. Essentially, the cells that line the womb, which we call the endometrium, are shed predominantly via the vagina with the period, but some of that blood and menstrual lining of the womb will go backwards through the fallopian tubes, what we call retrograde menstruation. And if you have the right genetics, which clearly a lot of women do, these cells can persist, or cells very similar to that persist within the abdominal pelvic cavity. Most commonly, they stick superficially as like blobs of vascular tissue, which you can see at something called a laparoscopy, which is a camera test to look inside the womb. Sorry, look inside the pelvis. And we think they cause inflammation, new nerve generation, and new blood vessel formation, and generally just cause pain. But we don't understand really the natural history and as to why it's triggering so much pain, but it's certainly associated with pain. About 1 in 50 women have what's called deep endometriosis, where this is endometriosis that rather than sitting on structures in the pelvis like the ovaries and the uterus and the bladder and the bowel, they start to invade a little bit and stick things together, and this can be more problematic to treat. But certainly it's a big problem in contemporary gynecology and causes significant problems with pelvic pain, and also for some women, fertility issues. Current treatments are generally medical, so hormonal medical treatments, because if we can suppress, in the same way as suppress the lining of the womb, if we can suppress these cells, which are very similar in the pelvis, these endometriotic cells, then we can hopefully render them quiescent and help with the pain. Often, however, these these common hormonal contraceptives do not, they can be very effective, but they often do not fully suppress symptoms, and so then we look at surgical intervention. Surgery generally involves laparoscopy, which I explained earlier, a keyhole procedure where we try and remove these blobs of tissue, and if there is some scarring and adhesions, that's because of deeper endometriosis, try and restore the pelvic anatomy. The problem is that as it's a hormonal dependent condition, so dependent upon estrogen, it can recur, and so surgery, you know, in and of itself is a part of the treatment armamentarium, but it's not necessarily something that's going to prevent ongoing symptoms or recurrence of the condition. And it's for this reason there's been interest to try and avoid the common necessity for repeated medical treatments or surgical intervention, is if we can give effective hormonal contraceptives immediately following surgery, can we prevent recurrence? You know, can we treat it, remove it surgically, and then prevent recurrence more effectively using these hormonal intervention? So commonly we use the combined oral contraceptive pill, which contains estrogen and progesterone, or you can use something called long-acting progestogens. So these are either delivered through an injection, which is a common contraceptive injection called the depot injection, or you can be delivered, as Jane spoke earlier, in attached to a little implant, if you like, a capsule attached to the plastic T-shape of a coil to sit inside the womb. And by releasing tiny amounts of this levonorgestrel, this type of progesterone, it can suppress the lining of the womb and also suppress, hopefully, endometrial proliferation and endometriosis. But we don't know which is more effective. Next slide, please. So we performed a randomized controlled trial, which is obviously the best design to do. It was very generalizable, over 34 UK centres over 5 years. We approached over 2,500 women to get the 405 that were ultimately randomized, and you can see that randomization is relatively balanced. Importantly, in randomized studies, to look at can we prevent recurrence, we wanted to go out to 3 years, which was quite an undertaking. So we were very pleased that we managed to achieve good rates of follow-up. Next slide, please. So you can see from baseline, we use something called the HP30. This is a condition-specific quality of life tool, the endometriosis health profile. It has a number of domains, around sort of sexual function, quality of life, etc. But one of its main domains is pain, which is the main presentation of endometriosis. So we use this as our primary outcome, and you can see from baseline a lower score on the HP is associated, means that things are getting better, if you like. And you can see there's a 40% reduction at 3 years in the pain scores calculated on this measure. And there was no difference between, in the blue, the long-acting progestions, that's a depot injection, or the Mirena. Patients could choose which they wanted, or the oral combined pill. Interestingly, looking at the other domains in the endometriosis profile, there was no apparent difference in those either, but our primary outcome was around pain, shown here. Next slide, please. Interestingly, no difference at 3 years in fatigue or general quality of life. And this probably does reflect the fact that, yes, it's good we can treat the pain, but the condition, these are more complex, multifactorial outcomes. And so it's probably not surprising, possibly a little disappointing, but certainly the pain was improved, but not the levels of fatigue or quality of life. Next slide, please. Interesting, if you look at this graph, around almost 25% of patients on average ended up with a re-intervention, usually further surgery or another sort of more radical hormonal intervention, which I can discuss afterwards. But if you did look at the blue line, the contraceptive pill, versus the yellow line, the long-acting progestions, it did favour the long-acting progestions. You can see it's just significant. So you're less likely to need an intervention if you if you were randomized to long-acting progestions rather than combined pill. Next slide, please. From a cost and effectiveness point of view, there was no difference really. We use Euroqual, which is a generic measure to measure the quality of life utility. We then applied costs. Ultimately, marginally seemed to benefit the combined pill. There was 61%, but it's just more than 50-50, but a 61% chance that it may be more cost effective. But if you did more sophisticated, what we call probabilistic analyses, where you changed assumptions, there was no clear message. So there's uncertainty really here. So I don't think you can choose one method over another based on cost effectiveness. Next slide, please. So the take-home messages, or the take-to-work messages, would be that that we know we've shown that long-acting progestions, whether it be the injection or the coil, and I should say there was no difference in subgroups between those types of delivery of long-acting progestions. We know that those and the contraceptive pill are equally effective, and they do reduce recurrence of pain. And you saw it consistently. We didn't show you in the graph at 6 months, 12 months, 2 years, and 3 years. Long-acting progestions, you're going to choose one, probably edge it, because they do seem to reduce slightly the need for further intervention, usually surgery. There's uncertainty around cost effectiveness, but these findings do certainly support the current guidance, but which is weak recommendations, but this is now much stronger given this trial, that we should be offering women hormonal treatments to prevent symptomatic recurrence. And this would hopefully help with shared decision making. And going forward, there are 1 or 2 newish hormonal interventions that we probably need to evaluate and to see whether they confer any benefits over the commonly used combined pill and long-acting progestions. Thank you very much.